Now, can I invite the next speaker, Dr. Alex Huang? He's from Chile University, and he's going to talk on conventional outflow imaging for medical and surgical care.
Well, I had two talks, and the second one was about anterior segment OCT. May fit perfectly.
Yes,
with
sir. You have
Sanjay.
another talk, sir.
Yeah, maybe
Anterior
we
segment
switch,
imaging.
switch the
Yeah,
order,
yeah.
yeah. Because
Yeah.
then they two go together.
Yeah, that talk is also there, sir.
Yeah.
So you want to do the two
Yeah,
together?
let's do that one, because we're following Sanjay. Yeah, the other one. No, I think the second to last one. Yes, that one. Okay, so this is a good talk to give, particularly after Sanjay's last talk, talking about the posterior segment OCT, because this is really about trying to do the same thing in the front of the eye. I thought we had 12 minutes, but I can go fast. Pearls and pitfalls, which really I describe this talk as otherwise known as what's wrong with anterior segment imaging, because clearly it's not the same. So here are my financial disclosures and my sources of research support. So I'm going to start with a question. How many of you people here on the left do posterior segment OCT, just like what Dr. Asrani said, every day, every clinic, almost every patient? Yeah, a lot of people should have their hands up. How many people do this on the right? Anterior segment OCT, every day, every clinic, almost every patient. Should be, wow, that's impressive. Usually it's very few hands. And because the thing is, you probably realize that posterior segment OCT in general has way more utility, both clinical and research, compared to anterior segment. So the question is, have you ever wondered why? Because if you understand why, then you know the problem, and how do we actually fix this, right? So let's just go through this historically. What's the landscape? The landscape is just like posterior segment OCT. You started with time domain, typically 1300 nanometer first, then moving eventually to spectral domain and swept source options at these wavelengths. This is just your typical commercial, most common commercial units out there now. In terms of what would you use, the first option is the only one that's not good because there's no benefit to be slow, right? So let's just take the top one out. That's the Visante. You can't even buy it anymore. So then you're left with these two options on the bottom, and you know, what's the difference? It's really the illumination wavelength. By definition, a smaller wavelength, you get better axial resolution, but you don't get depth. By definition, a longer wavelength, you get better depth, but you lose axial resolution. So this is not like I have the better machine or you have the better machine. It's just different, and it's a question of what are you trying to image? Because if you want to image the corneas all the way at the front, take the resolution. You don't need any depth. But if you want to go deep, you need depth, you need longer wavelength, you're going to have to give up the resolution. So welcome to problem number one. Anterior segment anatomy is so complex compared to posterior segment. So Dr. Asrani was talking about the optic nerve. I'm going to just talk about the retina here. For the macula, our colleagues in retina can make a decision on surgery and injection by imaging a location a couple millimeters this way, a couple millimeters this way, and 1 millimeter deep, and they can choose surgery. But in the anterior segment, from the front of the cornea all the way to the back of the lens, almost 10 millimeters. Diameter of the cornea, 12 millimeters. Pi r squared is the area. If you want to think about outflow and you're going circumferential, that's 2 pi r, over 35 millimeters at distance. The anatomy is huge. No wonder why it's difficult to make one machine to take care of everything. That's problem number one. Problem number two, anterior segment OCT has no tracking. Tracking is very prevalent in posterior segment OCT. Usually it's some concept where we're taking an image in the back of the eye, looking at the blood vessels to determine where we place the actual OCT. Tracking gives you three benefits. Number one, we create volumes. Because if you can put an OCT here and you can track, you know the next OCT is right next door, not like tilted this way or that way. Number two, tracking allows for longitudinal follow-up. Because if you put the OCT here, and if you can place it at the same location, next week, next month, next year, you can get the OCT at the same place again and actually have very precise follow-up. Benefit number three, tracking allows for averaging. You can take many, many OCTs now at the same place, again, average it, increase signal, decrease noise. So these are the benefits of tracking. So essentially the landscape is that posterior segment OCT was always imaging a tiny little area right in the macula or right the optic nerve head with tracking for everything, and anterior segment OCT is imaging a massive area with tracking for nothing. So then, okay, what can we do with this then? Here's one option. Start changing the wavelength and add tracking. So this is the anterior for Heidelberg Engineering. I have disclosures. They let me borrow a device for the purposes of research. So I have a conflict here. 1300 nanometer wavelength lets you image deeper. This is also the first anterior segment OCT with tracking that they know what's going on. And what are they tracking? They're tracking the corneal light reflex. They're using that information to put the OCT at the position that they want it. What that allows for is the creation of volumes and averaging by taking OCTs at the same place to increase signal, decrease noise. But you still cannot track over time because, you know, dry eye, or if the patient is not looking quite straight, the light reflexes might not be in the same spot. So clinically, what can we use this for now? Well, number one of these cataracts is scary. One of these cataracts is not. So because we have longer wavelength and we can get a better image, we can start looking at the back and starting to see that, you know, certain areas, this is a posterior polar, this is a posterior subcapsular, right? You're gonna need the depth, and if there's a bad cataract, you're gonna need the averaging with tracking to actually be able to image all the way through. What about this? There's a focal area of narrowing, like a pseudo plateau. Well, we can do the UBM, which is one way, but you know, UBMs are not that common. And OCT traditionally could not image this because lower wavelengths could not get through the iris. But with longer wavelengths, the same information can be gotten as well using anterior segment OCT. Here's an interesting case of mine that we didn't have OCT. This is a long time ago, about 13 years ago. A patient came to me with trabeculectomy. I did the cataract surgery. You can see the trab was very big. It was hard to see through that. Did well, but post-op week 1, pain and high pressure. I did a very narrow chamber, atropine YAG, did well. This is malignant. And as you know, malignant is a problem with that lens iris diaphragm and the anterior vitreous. Well, with longer wavelength, you can image deeper, and then with tracking and averaging, we can now make out the anterior hyaloid face as well. Look at the space of Berger. This becomes a tool that we can even start to interrogate this deeper anterior anatomy. Here's an example of then looking at the ciliary body. This is Dr. Xiaobing Xie, came to me for a year, did some work with this imaging. Focus on the ciliary body. I hope this works. Oh, there he goes. During accommodation, I'll go back. During accommodation, you see the ciliary body get bigger, the lens gets more anterior, the pupil comes down. You can actually now visualize Helmholtz theory of accommodation occurring right in front of you with a longer wavelength. Here's an interesting clinical case. 70-year-old male, history of retinal detachment with oil in the eye, came in with pain and high pressure. No wonder, you know, they overfilled, everything pushed forward. You can see the angles close. Retina, you know, decided to do the thing on their own, which is to remove the oil, reform the chamber. Then they were facing a case where IOP very, very low, and they couldn't understand why. But with longer wavelength and tracking and averaging, then we can image deep. To now, we can see the shallow choroidal detachment. As we were discussing with Dr. Azrani in the last session, if the ciliary body is detached from the posterior direction, you can have decreased aqueous humor production. And so in this case, now we know that the problem of why the pressure low is basically right there. This is also a very interesting picture to me because you have all this stranding. It reminds me of some of the old uveoscleral MIGs that have been out there and studied using OCT in the past. SciPass is here. We're really not talking about that, but this is mini-ject. A successful mini-jet case imaged with longer wavelength by Nuvalab at Liverpool also shows these little stranding webbing things. And so I've always been curious about what this is. I'm not sure what it is, but it occurs in cases where that area expands and the pressure is typically pretty low. So that was the first solution. Increase the wavelength, try to bring some tracking to the front of the eye. Second solution, application-specific OCT, right? Because the anatomy is so big. So many of you know, and you'll see in the other talk, I have an interest in anterior segment aqueous humor outflow. So what if we made an aqueous humor outflow specific OCT? And this is work I'm doing in collaboration with Hao Zhang at Northwestern University. The idea is that we need to optimize the wavelength and try to bring on board imaging that's perpendicular to the limbus for better results. I'll show you why on the next slide. To achieve this, basically it's a robot, or using a mouse obviously, to basically place the OCT and point it all the way around. Normal meaning perpendicular to the limbus. The reason why this is important is that because you think about it, a lot of our anterior segment OCTs are imaging straight down like this, and it becomes oblique to a lot of our target tissues. And essentially you have a longer optical path length as well as scattering. But instead, if you image more perpendicular to the target, you have a shorter distance, less scattering, better image. You know, we say it's normal, but since the eye is actually three-dimensional, we really mean conformal. So it's conformal imaging all the way around. work in mouse here by his team. In the blue is if this is straight imaging that's oblique. You get the image, but it doesn't look good. The signal to noise ratio is not great, but if you image perpendicular to the target, you get a much better image with also higher signal to noise ratio. So in the end, the idea with this application-specific anterior segment OCT, then we can actually build full circumferential imaging, right? Because this isn't an OCT for anything else, but just for outflow. And then you'll see in my next talk, these are the kind of concepts that we'd like to eventually bring to outflow imaging to understand what's going on and maybe help with some of our things such as trabecular MIGS. So in conclusion, you know, posterior segment OCT way better than anterior segment OCT. Why? Very small area, tracking for everything. Anterior segment getting better, we're having longer wavelength to look deeper, and we have some tracking for some benefit now. The other approach is to maybe consider application-specific anterior segment OCTs for each questions that we're looking at. Thank you.
Thank you so much for highlighting the importance of problems in the anterior segment imaging. Any questions?
So, would you like to replace UBM with AIOS2025 now?
Well, I mean, that's one thought, because the thing is that UBM, while it is very good, is a single device and does require touch and is manual, okay? So then you can say, well, then you can replace it with OCT, but then you just have to buy another machine, right? Is there really that much benefit other than the no touch as well as the no manual? I would say the benefit in a lot of these cases is that you start to create your machines with multiple functions, and then therefore it's just 1 square foot in your clinic. So you don't need 5 machines, you just have 1. So for instance, with the Anterior, it also does cataract measurements and other stuff, and the concept is therefore just 1 device. And if you can get something that does everything, then you really save space and save money because you only buy 1 thing.
Alex.
Yeah.
Yeah, I had a question. You initially asked us how many of us do routine anterior segment imaging in the clinic. What do you use anterior segment imaging for in the clinic? Like in which cases do you utilize it?
Just unusual angle assessments, looking at an LPI to see if it's patent. The answer is not very commonly,
Yeah.
There is one exception, and the exception is IOL Master has the anterior segment OCT in it. So technically, every time you get an IOL Master, you get an image. But it's cheating because, we only look at the first page. Yes?
Excuse me, ma'am. Is your experience of anterior segment OCT use in all these mixed procedure that are being done?
And for me, I only use it if things don't make sense. Because I haven't found that the structure alone yet, and this is the goal to get there, to use it to help us do the surgery and guide it. But at this point, it's more used on the back end, where then if things don't look right, then I'll kind of interrogate. Now, I'm not trying to imply that my surgeries always work, but unless something's weird, then I won't pull out the anterior segment OCT. Routinely, that is.